that protects you as well. We have hand washing and disinfection stations. We have people, disinfecting on a regular basis throughout the clinic. It is a policy to wear a face mask while on MFC premises. And you may see people in various higher levels of PPE depending on the duties that they're doing. So we've all been trained in what we need to do to keep everybody safe. So, we are, in that effort to continue with social distancing. There are no children, absolutely no children. So please make arrangements. We're trying to reduce the number of staff and patients on the premises at any one time. And we are still really doing virtual appointments for anything we can that doesn't require hands-on. So, access to the fifth floor is only for patients with the scheduled appointment or somebody receiving medical treatment. The exception to this is for the FET, you are allowed to bring one support person. This does not apply to the ERA, just the FET, and just on the day of the procedure. Notice that the chairs are all spaced 6 feet apart and they're taped off. And any higher risk patients might be scheduled, towards the end of the day or the end of the monitoring when perhaps there's less patients. So I'm not going to read this through, but I don't know anybody that's not familiar with the questions on this. But they are in the pre-screening. If you answer yes to any of these things, then you need to let us know. You probably will not be allowed access to MFC. And again, this is for everybody's safety. Okay, so we've done the housekeeping stuff. So let's talk about what we're here to talk about. So endometrial receptivity analysis, ERA, that's what we're going to call it from now. It just assesses the status of the endometrium. Is it receptive to the embryo, to the transfer? So the window of implantation is pretty short when, things are really ready to accept an embryo. And literature says do the transfer day 6. So that is what we do. And with this test, what it tells us is day 6 truly your receptive time? So we're going to talk about the protocols in a minute, but this is just kind of the bones of what it is. You do your protocol, your lining would be approved by the physician. We book the ERA biopsy. That time and date can be found in your portal because you would be cycle monitoring leading to that point. It's done on the 6th day after ovulation. The doctor will determine that. The results take about 10 to 12 business days in general. So usually patients can book their next cycle with day 1 for an FET. There are times when the results do not come back in time. And then we have to wait another cycle. So the FET, or frozen embryo transfer, again, you would do your protocol. The lining is approved by the physician. The lab will contact you with the date and time. And if you've done an ERA, we will make that adjustment based on those results. It's easy peasy. On the day of the FET, you meet with the physician doing your transfer and reminding you that it may not be your particular physician, and you're allowed the one support person. So let's talk about the protocols. So really important to understand that an ERA protocol should mimic the plan for your FET. And the protocols are going to be individualized by your physician, and they're going to look at your case history in mind, what is the best option for you. The other important thing to keep in mind is what is important is the exposure of your lining to progesterone. And I'm going to come back to this. So we have three options, different options for the protocols. We have a natural, we have a HRT, that's hormone replacement, medicated, and we have an injectable gonadotropin medicated cycle. And so let's break them down. So the natural cycle protocol is going to be very much the same for an ERA and an FET with one minor difference. So who is a candidate for this? If you have a regular ovulatory cycle, tick mark. Your lining needs to get to an appropriate thickness and appearance, tick mark. And your physician's going to decide what is appropriate for you. So here's an example of how a natural cycle is going to work. So let's just say you have a 28-day cycle. Blood-only monitoring starts around day 10, and this day can shift depending, if you have a shorter cycle, then we might start the monitoring a little bit earlier. If you have a longer cycle, we might start the monitoring later. So bloods are monitored until a surge is detected. Typically, 4 or 5 days of monitoring, but it could be more and it could be less. This is where the individual comes in. We like to start, a little bit early so that we hopefully don't miss anything. So we see the surge, we do the lining check. Sometimes additional blood work is required so that we can, sometimes, you need the day after to make sure that where the peak has landed. And with that, the ERA is scheduled 6 days from ovulation. With the ERA, no medications are required. You're going to have your biopsy and then that ends the ERA. With the FET, we do the same monitoring, and it doesn't matter if you surge on day 14 in one and day 15 in another. It's the time from when you surge that becomes important. So for an FET, we would schedule that 6 days from ovulation, or if you've done an ERA, we're going to look at the ERA results. Are you receptive? It stays on the 6th day. Are you pre-receptive? And they say you need to do it later. We move it later. If you're post-receptive, then we may move it earlier. So that's how we adjust based on those ERA results. Now, the difference in this cycle is that we're going to add the progesterone and oil, PIO, the same day as the FET as added support. Okay, so that's the natural cycle. Hormone replacement cycle, or HET, is a medicated protocol, and it is where they use exogenous estrogen, meaning it comes from outside. It's not what your body's making. We're actually taking over the cycle in this. We're making the cycle. And so the estrogen hormone therapy helps to thicken the lining and prepare for implantation, but it also helps to prevent ovulation. It's not the be-all and end-all, but it helps. It can be oral, it can be vaginal, it can be topical, it can be a combination thereof. Again, your physician's going to make that determination. So who's a good candidate for this? Well, say your lining never gets thick enough on the natural cycle, or say the natural cycle, you've done that, maybe you've done it once or twice and it didn't work. So what can we do? We can add something different and do it this way. If you have a very irregular cycle, it's hard to do natural because it's just hard to catch things. So we make the cycle and we control it. Maybe you have travel concerns. This is really an appointment for the lining check, and you come for the transfer, so it's a lot less traveling. So with this one, medications are going to start on day 2 of your treatment cycle, or maybe 3, and you'll do the medications for about 2 weeks. Now, your team will give you your specific medication protocol, and they will give you your specific timeline. So roughly